Hi everyone, welcome to MRA's presentation of the NCCI Manual Overview. I'm Susan Bonham and I'll be your presenter today. Welcome to the presentation. First slide here is just our disclaimer that every reasonable effort has been taken to ensure the educational information provided is accurate and useful. Please do take the time to read the rest of that disclaimer and so that you know what we have in there. We'll just start with the basics. The NCCI manual is often an overlooked when it comes to coding, but it does contain a lot of invaluable information for the coder. We're just going to go through mostly Chapter 1, the general correct coding policies. We'll dip in a little bit through a high-level overview of the individual chapters, but mostly the presentation today is going to be in Chapter 1, the general correct coding policies. The NCCI procedure to procedure or PTP edits are updated quarterly, so do keep that in mind. Everybody's really used to ICD-10 and CPT codes being updated annually, but these procedure to procedure edits are updated quarterly, so do keep that in mind as you're coding. The NCCI manual was developed by Medicare, or by CMS rather. It prevents inappropriate payments for procedures that should not be reported together. So either a column 2 code is a component of the column 1 code, or the two procedures simply should not be reported together. There's a table that's used, and we call that the column 1, column 2 table, and you can reference that online to have it while you're coding. Unless medical necessity permits, a column 1 code would be eligible for payment. The column 2 code then would be denied as being included. With appropriate medical necessity documented, a modifier may be reported to allow payment for both codes in some cases, in some circumstances, and we'll go through some of those. Mutually exclusive procedures cannot be reported together. Gender-specific CPT codes, of course, should not be reported for a patient of the opposite gender. Unlisted procedure codes are usually listed as the last code of a section of the CPT book. These codes, however, are not included in the NCCI manual. So unlisted CPT codes, of course, are used for multiple procedures that are not described by a more specific code in the CPT section that you're coding from. We'll start now with the MUE edits, and we'll go through what this means and elaborate much more on this. So MUEs are medically unlikely edits. They are part of the NCCI manual. This edit limits the number or quantity of a service that can be provided. HCPCS and CPT codes are given an MUE value, and that value is the maximum number of units that can be billed on the same date of service. All claims that are submitted to MACs are subjected to MUE edits. Denials may be appealed. So if you get a denial, don't just automatically say, oh, we're not going to get paid. It is possible to appeal. All of that, of course, is based on your documentation, what services your documentation supports. We'll talk a little bit about that more in the presentation as well. When claims are processed, they are adjudicated as either a claim line or a date of service edit. So we'll go through what each of those means. A claim line edit is units of service on each claim line are matched to the MUE value. All units of service are denied on that claim line if the MUE value is over the maximum number allowed. A date of service edit is used when it's highly unlikely that more units than the MUE value would be performed on a given date of service. So all units of service on each claim line for the same date of service, same HCPCS CPT code, are totaled together. If that total exceeds the maximum, then all units are denied for that HCPCS CPT code for that date of service. An MUE adjudication indicator, an MAI, is an MAI of 1 is a claim line MUE. And with the use of a modifier as modifier 59 or the X modifiers, XE, XP, XS, and XU, a 76 modifier, 77 modifier, 91, or anatomical modifiers. When you use those modifiers, then each line with the HCPCS CPT code then are separately adjudicated. And then some CPT HCPCS codes limit the use of these modifiers. So you have to know what your code allows as far as modifiers in order to append those modifiers. Also, can express enough the need for your documentation to always back up what you're reporting and the codes that you're reporting, along with the modifiers that you're reporting. And we will go through some of these modifiers later in the presentation a little bit more in depth. An MAI of 2 is a data service MUE, and these are fixed data service edits. So with these edits, it is considered impossible for the units to exceed the MUE value on the same data service due to being contrary to statute, regulatory, or sub-regulatory guidance. Correct coding limitations and or anatomical limitations would also then preclude this reporting more than the designated number of units on the given dates of service. So a data service modifier, a data service MUE, a date of service MAI MUE, sorry about that, are fixed for that data service. So here's a couple of examples listed for you. So reporting multiple units of CPT code 44950 in appendectomy would be inappropriate. Its anatomical consideration is the limiting factor for this edit. So we only have one appendix, so there's not a need to have more than one unit of an appendectomy reported. So never will you be able to bill more than one unit on that code. So that's an example of an anatomical consideration being the limited factor. Reporting multiple units of CPT 16000, which is an initial treatment of the first degree burn, and then it goes on with a much more in-depth description of that code. The code descriptor in this case is the limiting factor for this edit. So the code descriptor says initial treatment. So you can only have one initial treatment of a burn. So reporting more than one unit would go against correct coding based on the code descriptor. Of course, in this section of the CPT book, there are additional codes for those subsequent treatments and so forth. So, but to bill this initial treatment, there is limited to one because of the code descriptor is the limiting factor on that example. An MAI of 3 is a data service MUE, and these are based on clinical benchmarks. So it's possible, but not likely, that more units would be performed during one date of service on these edits. Contractors may bypass the MUE edit if presented evidence that the number of units reported were correctly coded and medically necessary. Cannot stress enough and overemphasize the medical necessity throughout this NCCI manual when you're talking about trying to override an edit of some sort. Your medical necessity has to be documented clearly in your documentation. A couple of examples that I have here for you. CPT 48020, which is the removal of pancreatic calculus. So clinically, it's highly unlikely that you'd perform this procedure more than once per date of service, but they don't rule it out 100% completely. Even though it's highly unlikely, documentation could support doing that twice in a day. But again, it's highly unlikely. CPT 49060 is the drainage of a retroperitoneal abscess open. The MUE on this procedure is 2. So again, while it would be possible to perform a drainage procedure more than twice per date of service, they've deemed this to be highly unlikely based on clinical benchmarks. So based on the standards and clinical evidence there, they're saying 99% of the time this will not be done over this value, whatever value is placed on the code. So again, documentation is key if you're trying to override these edits. So denials, we're going to talk about denials on this slide, and you may appeal denials based on the MUE denials. Again, I've said it already, documentation is key. So they will ask questions, a contractor will ask questions to decide on overriding a denial. Did the provider actually perform more units than allowed? Does the documentation support that they actually did perform more units than are allowed? And were these services medically reasonable and necessary? Again, your medical necessity is key, and your provider's documentation is what is going to show that. Denials may be appealed for an MAI of 1 or of 3. So again, that 2 category is not able to be done. that's, trying to do 2 units on an appendectomy was my one of my examples there. So that's absolutely anatomically based reasoning that cannot be done twice in a date of service. So the appeals are for MAIs of 1 or of 3. And it is not appropriate to have a beneficiary sign an ABN in order to bill the patient for an MUE denial, because these denials are not based on statutory provisions. So an ABN would be inappropriate. We'll go through some coding instructions on this slide. So HCPCS CPT code descriptors should be referenced before reporting codes together, as some codes include redundant services and those codes should not be reported separately. So some codes list out several things that are included in that code. So always read your descriptors. They will often define the correct coding for you, and starting with your CPT code descriptor is where you should start to determine if 2 codes should be reported together, or if 1 code captures all the services that your provider did that day. There are coding instructions included prior to each chapter and in the appendices of the CPT book, so those should be looked at as well and referenced to make sure that you are coding appropriately. There are also instructions found prior to the subsections of the chapter and also after some individual codes. So all throughout the CPT book, there's coding instructions that should be referenced and followed when thinking of how many codes to report for the services that are provided. And those instructions should be followed unless CMS provides specific coding or reporting directives. And I'm sure everybody has a certain set of codes that CMS has defined specifically what can and cannot be done together. And so just keep in mind that when CMS provides that specific coding directives, those should override the CPT instructions. The AMA does also publish the CPT Assistant, and that does have coding rules as an additional tool. Sometimes, however, you'll find, and I'm sure many already know this, CMS doesn't always agree with the CPT Assistant advice. And so we're kind of left in a conundrum sometimes of what to do. But CMS has very clear instructions on certain CPT codes, and we have to follow that when we're reporting to CMS. MACs may process claims differently than the advice from the CPT assistant, so just know that when you're using those CPT assistants. All codes should be reported with the most comprehensive CPT code available. And so we would not report multiple HCPCS or CPT codes if a single code describes the services performed. So an example would be a provider performs a laparoscopic cholecystectomy with a cholangiograph. And so in this case, it's inappropriate to report the lap chole code, the 47562, and also the 47563, which is a lap chole with a cholangiogram together. You would only report the more inclusive code, the 47563, which includes both services, the basic lap appy service and the addition of the cholangiograph separately. So that one code captures both of those services that are provided. Also, you don't want to break up a procedure into component parts. So an example is a provider performs a colonoscopy with a biopsy. So it's inappropriate to report, So if a provider performs colonoscopy with a biopsy, it's inappropriate to break that up into component parts to do the biopsy separately. So it's inappropriate to report 60650, which is an adrenalectomy, with 50545, which is a radical nephrectomy, because the parenthetical descriptions within 50545 lists the adrenalectomy as a component of the nephrectomy. So again, referencing those parenthetical descriptions and instructions in the CPT book lends you to know then you cannot bill these 2 codes together. So you do not unbundle bilateral services either. If a bilateral procedure is performed, do not report the unilateral procedure CPT code with 2 units or on 2 lines with right and left modifiers. If the code is a bilateral code, that's the code. It's 1 unit for a bilateral code. An example would be a provider performs bilateral venous thrombosis imaging with a venogram.
You would not report 78457 with 2 units. 78457 is venous thrombosis, imaging venogram unilateral. So you would not use that code with 2 units, nor use that code with a right and a left modifier. Instead, you would report 76858, which is a venous thrombosis imaging venogram bilateral. So when a bilateral code exists and the procedure is performed bilaterally, that code is reported with 1 unit. Also, do not unbundle services that are integral to a comprehensive procedure. Certain services are integral to a more comprehensive procedure and should not be unbundled. So make sure that you know what your comprehensive procedures are, what services are then integral or included in that comprehensive procedure, so that you know that you're not unbundling those incorrectly and inappropriately. There are also family of codes, which are a group of related codes. They may describe component services. They may also describe various combination of components. So just make sure you know when you're dealing with a family of codes what's included and what's not. All services included in the code must be performed in order to report a CPT code. I said earlier, mentioned about the unlisted codes. A lot of times we're kind of off put to use those unlisted codes, but when a CPT code does not exist that supports or that defines what you're doing, those unlisted codes sometimes do have to be reported. In the family of codes, multiple codes should not be reported for a component service when a more comprehensive code exists. So they do in the NCCI manual have limited exceptions to this. So just know that this manual again has invaluable information as far as how and when to report codes separately. A code describing the component service should not be reported with a comprehensive code. If a code doesn't exist to describe a service performed, a not otherwise specified code would be reported. So you do not use a code that is close to the service provided. Again, sometimes that lends you to having to use an unlisted code, but you can't just code the code that came the closest to the services that were provided. It has to support the services that were provided. More extensive procedures, a group of similar codes differing in complexity only. A less complex code is included in the more complex code, unless for 2 reasons. 1, the services are performed at a separate encounter, or the services are performed on different anatomical sites. So simple procedures are included in complex or complicated procedures. So when a CPT code descriptor says simple, and then there's another code that says complex and or complicated, the simple is always included in the complex. Limited procedures are included in a complete. So if your descriptor says limited, then there's generally another code that will say complete. Your intermediate procedures are included in comprehensive procedures. Superficial procedures are included in deep procedures. Incomplete procedures are included in complete. External procedures are included in internal. So again, there's limited number of reasons to be able to bill these separately, and those are listed here for you. If the service is performed at a separate encounter or different anatomical sites. A separate procedure is a CPT code that is defined a separate procedure that says it cannot be reported with a related procedure. So coders are unable to report a separate procedure code performed in the anatomically related region. Often this is done through the same incision, orifice, or surgical approach. A modifier may be reported for certain circumstances. For example, an unrelated anatomical location through a separate incision at the same encounter. Then you may be able to report this separate procedure separately. We'll look at downcoding and upcoding now. A less comprehensive code should not be reported in place of a more inclusive code, which we've already stated. So those less comprehensive codes are included in the more comprehensive code. An example is a physician performs arthrocentesis of subacromial bursa with ultrasound guidance. So you would not report to 20610, which was arthrocentesis without ultrasound guidance, and the CPT code 76942, which is your ultrasound guidance code. Instead, there is a CPT code that includes both of those services, 20611. So you would not report the less comprehensive code separately. You would report that bundled code that has the arthrocentesis and the ultrasound guidance together. If all services described by the code isn't completed, you would not report the more inclusive code. So if a provider performs a simple IND of pilonidal cyst, you would not report CPT 10081, which is the IND of a pilonidal cyst complicated. Instead, you would only report 10080, which is the IND of pilonidal cyst simple. So if those words descriptors are not supported in your documentation, whether it be complicated, simple, multiple, those kind of words have to be met in your documentation to support the more comprehensive code if that's what you're wanting to report. We also would want you to be sure that you're reporting the units of service correctly. And providers should be familiar with the criteria of what constitutes a unit of service. Some codes are reported per time increments. 97110 is a therapeutic procedure, one or more area for each 15 minutes. So 1 unit of service is each 15 minutes. Some codes, however, are per session. 92507 is the treatment of a speech disorder, and that's per session. So you have to be very familiar with what your code says a unit of service is in order that you are appropriately reporting your overall units of service, because some codes are very different. We'll look at the medical surgical package, the general guidelines. Most procedures do include pre-procedure, an intra-procedure, and a post-procedure work. And so you want to make sure that you're not unbundling these areas when they are all included together in the package. Vascular and or airway access. So the work associated with gaining access is included in the pre or intra-procedure work. The work associated with getting the patient back to a suitable post-procedure state is included in the post-procedure work. These are just kind of some examples that are what's considered in each area. Airway access is essential for general anesthesia and therefore is not separately reported. Intravenous access is not reportable with many types of procedures. So you want to make sure you're knowing what is and isn't included, and therefore if it's included, it's not reportable. Access must be maintained by slow infusion, and that is not reportable. So your access has to be maintained. So in coding for that infusion would be inappropriate there. If a procedure requires more invasive vascular access, the more invasive procedure may be reported if it isn't included in the evaluation of the procedure. In anesthesia, services by the same provider performing the surgical or medical procedure. If it's reasonable and necessary for another provider to give the anesthesia service, these services may be reported by the other provider. So otherwise, again, that first bullet there, services by the same provider are considered included. You do not unbundle components of anesthesia and report them in lieu of anesthesia services that are not reportable. So if the same provider performed the surgical procedure and does the anesthesia, he cannot unbundle that component and then bill that anesthesia service separately. Endoscopic procedures performed with a non-endoscopic procedure in order to make sure no injury occurred or just to confirm the procedure was correctly performed is not reportable. So if they're only confirming placement of whatever they place, something like that, then those endoscopic procedures are not reportable. If cardiopulmonary monitoring is integral to the procedure performed, it is not reported separately. For biopsies, a biopsy is performed at the same time as another extensive procedure. If a biopsy is performed on a separate lesion, modifier XS or 59 is allowed to report the separate lesion. If a biopsy is used to access margins or resectability, it's not reportable. If a biopsy is submitted for pathology that will be completed after the more extensive procedure, it's not reported separately. So just make sure that you know the reason behind the biopsy being performed, whether it was performed at the same time as another extensive procedure, or was it a separate lesion and they just did that biopsy while they had the patient under anesthesia. Things like that you have to look at and know. Your documentation has to be very clear and very precise so that you know whether the modifiers are allowed maybe to unbundle that biopsy, or if it's really just included in the more extensive procedure. Exposure and exploration of the surgical field is integral to a procedure and is not reportable separately. If access through a diseased tissue is required in order to perform a definitive procedure, services for that access is not reportable. So if you have to access through something, if you have to remove something to get where you need to go, then services for gaining that access is not reportable. If elimination of a lesion requires coincidental elimination of other pathology, only the primary procedure is reported. So if you had to take something to get where you needed to be, again, that's not reported separately. Excision and removal includes the incision and the opening. A code for an otomy should not be reported with an ectomy for the same organ. So know your terminology, a little terminology flashback for you there on that example. Multiple approaches for the same procedure are mutually exclusive. So when a procedure starts laparoscopic, it fails, it's converted to an open, then only the open procedure should be reported. You would not get credit and be able to report that laparoscopic portion separately. If a diagnostic endoscopy precedes an open procedure, the diagnostic procedure may be reported with modifier 58 reported on the open procedure, meaning that you needed to do that diagnostic endoscopy in order to know whether you want to proceed then with that open procedure. But modifier 58 on that open procedure is going to unbundle that edit for you. Complications are reportable very limitedly. So OR procedures include services that are normally and usually necessary part of the procedure. Post-operative services that do not require a return to the OR are included in the global package. So anything that you're doing post-surgery that do not require an OR, trip back to the OR, are included. We're going to talk about global days in a few minutes, so we'll get into that a little bit more then. Complications are not reportable, again, when the services are normally provided in the OR during the procedure. So anything done during the procedure in the OR is not reportable separately. Complications occurring during the post-op course, but doesn't, again, require a return to the OR. Those are not reported separately. So a couple of examples for you. Control of post-op bleeding that can be treated without a return to the OR is not reportable. So that's just included in the procedure that you're already reporting. However, post-op bleeding that requires a return to the OR is reportable separately. We'll move on now to evaluation and management. So in order to determine if an E&M service is reportable at the same time as a surgical procedure, you will need to know the global period of the procedure that's being performed. All procedures have a global period assigned. There are categories of 0, 10, 90. There's an XXX, a YYY, a ZZZ, and an MNM. And we're only going to go through the 0, 10, and 90. The other three, the XX, XYYY, and ZZZ, are there for you on the screen. So if you work in maternity, for instance, you would need to know what the MMM stands for and how that relates. So a global period of 90 is defined as a major procedure, and E&M services performed the day of or the day before are included in that global period, except if that patient is seen for an E&M service and it's decided at that encounter to perform that surgical procedure. Modifier 57 would be reported with the E&M code. So the day of or the day before a 90-day major procedure, the E&M can be reported if that's the visit that the decision is made to do that surgery. So if the patient comes in the day before a 90-day major procedure service and it's simply a pre-op visit, just to make sure they're still stable for surgery, you've already decided to do the surgery, it's already scheduled, already on the books, that service is considered included in your major procedure. Global periods of 0 or 10 are defined as minor procedures, and generally E&M services on the same day as a minor procedure are included in the procedure. Unlike major procedures, however, the decision to perform a minor procedure is included in the procedure. A significant separately identifiable E&M service is separately reportable with modifier 25 if there is a significant separately identifiable service provided at that same visit. Separate diagnosis is not required. And also the same rules apply for a new or an established patient. So just because the patient's new and you do an E&M service, decide then to do that minor procedure right there that day, just because that patient's new doesn't automatically allow for an E&M service. The E&M service provided, again, still has to be significant, separately identifiable from the procedure that's performed. Otherwise, it is included in the procedure. Postoperative E&M services are included in both major and minor procedures during that global period. So whether that's the 10 or the 90, the 0, of course, has 0 days. So there would be no post-op for those. But 10 and the 90, those are the number of days. So complications are also included unless, again, we've already talked about, the complication required a return to the OR. E&M services during the post-op period for an unrelated diagnosis may be reported with modifier 24 appended to the E&M code. So if you're seeing that person in that post-op period for an unrelated diagnosis and unrelated reason, you can report that. You just need to make sure you have that modifier on there. We will talk about modifier global surgery indicator XXX now. Usually pre, intra, and post-procedural work performed is included in the procedure, and these services should not be reported as an E&M service. Some XXX procedures are not typically performed by a physician and thus have no work RVUs. A separate E&M is not reported for the supervision of others performing the procedure or an interpretation of the procedure. A separate E&M may be reported if the physician performs a separate identifiable E&M service on the same day. A separate diagnosis, again, isn't required, but it can't include work inherent to the XXX procedure, supervision of the performance of that procedure, or time interpreting those results. If you have the instance where the physician does perform a separate and identifiable E&M on that day, modifier 25 would be appended to the qualifying E&M code. A word a little bit now about modifiers we'll go into. I can't stress enough to only append modifiers if it is clinically appropriate to do so. Modifiers should never be used solely to bypass an NCCI edit. So I can't overemphasize that enough either. We can't just throw a modifier on a code so that it passes the edits. The documentation has to meet the requirements. The medical necessity has to meet the requirements. So you do need to look at those restrictions that Medicare has before you append to modifiers. These are the modifiers available to bypass an NCCI PTP procedure to procedure edit. I'm not going to read all of those out for you, but those are the reportable modifiers. The two repeat procedure modifiers, 76 and 77, are not NCCI PTP modifiers. They will not bypass an edit for you. Excuse me. Most paired organs or structures have NCCI procedure to procedure modifier indicators of 1. So this procedure is performed on the contralateral organ or structure for a paired organ or structure. Code pairs should not be reported with a modifier when performed on the ipsilateral organ or structure unless a specific coding rationale to bypass the edit is documented. Again, modifiers should only be reported when appropriate. Generally, modifiers are appropriate to report a separate patient encounter. Maybe they're seen in the morning, they come back in the afternoon, that sort of thing. Or a separate anatomical site is worked on, a separate specimen is taken So those are just general, some reasons to use modifiers. We'll go through several modifiers now that do impact NCCI power procedure to procedure edits. This first one, however, modifier 22, doesn't bypass an edit for you, but it is addressed in the manual as it can be relevant to an edit. So this is an increased procedure services modifier. In order to report this modifier, services should be substantially more extensive than what is usually included in the given HCPC CPT code description that you are reporting. So the provider does a procedure and it's substantially more extensive than what is typical for that code that he or she's reporting. Modifier 22 can be used. Again, documentation's key. I can't say that enough. 2 procedures performed that should not be reported together based on an NCCI edit. So if the edit allows a modifier and clinical circumstances support the use of a modifier, then you should report 2 procedures rather than the modifier 22 on one procedure. So if an edit does not allow a modifier and the procedure meets the definition above, this should say modifier 22, sorry about that, may be appended to the column 1 code. So if your clinical circumstances support, the NCCI edit allows the use of a modifier, you should report the 2 procedures. If they're not allowed, then's when you think about how substantially more extensive was this procedure, this extra done on this procedure, and does it allow me to use modifier 22? Next is modifier 25. This is a CPT manual description that I've given here for you. Significant separately identifiable evaluation management services by the same physician or other qualified healthcare professional on the same day of the procedure or other service. So this is appended to an E&M service on the same date of service as a minor procedure. The work associated with the decision, however, again, I've already stated, the decision to perform that minor procedure is included in the procedure that's performed. So with a major procedure, you kind of get credit for that decision to perform it, but not with minor procedures. The patient designation of new or established has no bearing on whether to report a separate E&M. So do keep that in mind. Modifier 58, again, your CPT manual definitions listed here for you. It's a staged or related procedure or service by the same physician or other qualified healthcare professional during the post-op period. The second procedure performed during the post-op period of a prior procedure. It's either planned prospectively, it's more extensive than the first procedure, or it's for a therapeutic procedure after a diagnostic procedure. So diagnostic endoscopies, if a diagnostic endoscopy results in the decision to perform an open procedure, modifier 58 is reported on the open procedure. If, however, the endoscopy procedure is a scout, just to access anatomical landmarks, just to kind of look around, peek around, see what's there, that is not reported separately. It needs to be a diagnostic endoscopy results in the decision to perform an open procedure. At the same encounter, a diagnostic endoscopy of the same organ or anatomical region is not reported with another endoscopy procedure. A diagnostic laparoscopic and a surgical laparoscopic of the same body cavity is never reportable together. A planned laparoscopic procedure fails and converted to an open, then only the open procedure is reported. This statement is applicable whether there is an NCCI edit or not. So even if there's not an NCCI edit, if a lap fails and you convert to an open, then only the open is reportable. There are more bundling possibilities than the number of NCCI edits. Just because the specific combination isn't included in the NCCI table edit table, both the failed laparoscopic and an open should not be reported together. We'll move on now to modifier 59. This is a very, very misused modifier. Documentation has got to support the 2 procedures that are not normally performed together in order to qualify them to be reported separately. Typically, that's a different anatomical site, different patient encounter, something to that effect. And it should only be used when there are no other modifier that can more accurately describe the situation. So if there is a more applicable modifier that shows your situation, please use that rather than modifier 59. It's not reportable on NM codes. Modifier 59 should never be used simply to override an edit. Your documentation must support the use of modifier 59. There is a lot of misuse of this modifier out there, and so I can't overemphasize enough making sure that you're accurately reporting this modifier. More on modifier 59. Two codes of an edit indicate two procedures can't be reported together if the same anatomical site and the same encounter. So modifier 59 isn't supported based on the two codes being different procedures. If the two procedures are performed at the same anatomical site or a separate encounter for the same data service, modifier 59 may be reported. Your documentation has to support that, however. There's a few exceptions. We'll go through. A diagnostic procedure can be reported if it precedes and is the basis to decide to perform a therapeutic procedure. So it's not interspersed with services required for the therapeutic procedure. It clearly provides information to decide to proceed with the therapeutic procedure. And it's not a service that would have been required during a therapeutic procedure. Diagnostic procedures cannot be reported if the procedure is an essential component of the therapeutic procedure. So you do keep that in mind. If it's essential, an integral component, then it cannot be reported separately. Diagnostic or procedures that can be considered separate and distinct if it occurs after the therapeutic procedure and it isn't interspersed with services required only for the therapeutic procedure. Also, if it's not a service that is required during the therapeutic service. A post-procedure diagnostic procedure is not separately reportable if the diagnostic procedure is essential or otherwise included in therapeutic procedures. So with those diagnostic therapeutics together, you really have to know the reasoning and then how they were performed. For time-based codes, modifier 59 can be used to report two separate services provided by two distinct blocks of time. So your time blocks are very distinct in your documentation. It's clear, then modifier 59 would be appropriate in those cases. They're not allowed to report multiple services for minimal time and then to report each as separate units of service. So make sure you're, again, going back to those CPT descriptors in the CPT book, make sure what a unit of measurement is and what your documentation supports. All related time services performed are totaled, and the total time is used to calculate the number of units. Different diagnoses are not required to report modifier 59, but a different diagnosis alone also doesn't support the use of modifier 59. We're looking for different organs, different anatomical regions, different lesion. It does not include connecting structures of the same organ or region. Again, evaluate your code descriptors to determine your additional units based on what the code descriptors have. Modifiers X, the X modifiers, XE, XS, XP, and XU, provide greater specificity when modifier 59 was previously reported. Was effective 1/1/2015, but is not required, but it will be required in the future. So just know what these are and when to use them. Separate encounter, separate structure, separate practitioner, unusual, non-overlapping services are what these are for. So we'll go through some anesthesia information. Preparation and monitoring services are not reported separately. They are separately reportable if they're performed by the same provider prior to and unrelated to the anticipated anesthesia services after the patient is released from anesthesia provider's post-op care. And those would be reported with either modifier 59 or those X modifiers. Generally, payment for the anesthesia provided by the provider who also performs the surgical procedure isn't allowed. An exception is for moderate conscious sedation. Services are not related to the delivery of an anesthetic agent or not inherent to the procedure. They may be reported separately. A surgeon is not allowed to report epidural, subarachnoid injections, or nerve blocks if he's the same physician performing the procedure. Add-on codes in the edit table, they are never reported alone. There must always be a primary code with those add-on codes. These are incidental services needed to perform the primary procedure and should not be reported. Incidental services needed to perform the primary procedure should not be reported with an add-on code. NCCI generally doesn't include edits for add-on codes, so just know that these are typically not on the table. Some add-on code edits, though, are included when the primary procedure edits must be supplemented. CPT codes not designated as add-on codes cannot be used as an add-on code. So all services included in the CPT code must be performed in order to report the code. So CPT codes 00000 through 01999 are the anesthesia services category. And so from here, the rest of the presentation, we're going through each chapter. And these are really just the high-level overview of each chapter. The anesthesia chapter, for instance, includes many examples of services that may and may not be reported in addition to the anesthesia code. So please go to the NCCI manual and look at if this is your area of coding, and really look at the NCCI chapter on anesthesia, each chapter that we're going through, and make sure that you have a handle on what is allowed and is not allowed here. These are services that are included: the pre-op eval, the administration, of course, of the anesthetic, the meds given, monitoring and supportive services. They are broken down by anatomical area and include several surgical procedures. However, only one anesthesia code should be reported. Time units are also used to report anesthesia services. They start when the provider begins to prepare the patient and ends when the provider is no longer providing care to the patient. Any interruption of care should not be counted toward time, so you got to keep up with your time on the anesthesia services. CPT codes also have an associated base unit for anesthesia. And post-op pain management, when it's requested by a surgeon, then that surgeon has to document the reason for this request in order for the anesthesia provider to be able to report these services. Sometimes that's kind of tricky to get done, but your surgeons have to realize how important their documentation is, not just for their services, but also for the anesthesia. Because CMS Global Surgery Rules states the performing provider is responsible for that post-op pain treatment. So when he's giving that to somebody else, he has to say why and give that reasoning. The intake system, CPT codes 10000 through 19999. Again, every chapter has so many things that I could not put on these slides. So I encourage you to go back and look at those. Wound closures include using steri-strips or tape are not reported with a closure code. Rather, those are included in the E&M codes. Suture removal and dressing, they're not reported if the patient requires anesthesia for a related procedure. So you already have them in a related procedure under anesthesia and you take those sutures out, you can't report that suture removal. Dressing change code 15852 should not be reported with any primary procedure. Closure of a surgical wound is included in the procedure except for these couple of examples that I give here. Fine needle aspiration cannot be reported with a biopsy of the same lesion. Don't report tangential, punch, or incisional biopsy with a destruction of benign or premalignant lesion. Again, unless it's on a separate lesion. So for the same lesion, you would not report the biopsy with a destruction code on the same date of service. You don't report trimming of non-dystrophic nails with debridement of nails unless, again, the procedure is performed on separate nails or at separate patient encounter. So a lot of these things, a lot of the intake system does really go back to separate lesions, separate nails, separate entity of the body, or a separate patient procedure, or patient encounter. Musculoskeletal is next, CPT codes 20000 through 29999. Diagnostic arthroscopy is included in a therapeutic procedure. If a diagnostic leads to the decision to perform an open procedure, again, we've said several times you can report that with modifier 58. If a more extensive procedure is performed after a cleanup savinectomy, the savinectomy isn't reportable. Again, that cleanup portion. Coders and providers of spine procedures, please look at this section F because it includes a lot of instructions that I was not able to include here. Casting, splinting, strapping codes are not reported if a definitive procedure is also performed. Those are considered minor procedures and include an E&M service unless it is separate identifiable that is provided, and it must be documented that way. Closed percutaneous and open repair codes for the same anatomical area are mutually exclusive. So I can't stress enough going back and looking at these individual chapters separately if it's your area of coding, because there's a lot of covered. Section G here in the musculoskeletal, Section G covers a lot of examples in regards to multiple manipulations, fracture care, dislocations. So please go back and read that carefully. For time's sake, I was just not able to include it in the presentation today. Respiratory, cardiovascular, hemic, and lymphatic systems, CPT 30000 through 39999. We'll go through each one of those listed there separately a little bit. Respiratory, I'm just going to hit the highlights on these chapters. Procedures performed at or near the mucocutaneous margin. The code that best describes the procedure should be reported, either a code from intake, nasal, or oral. So you really have to know where they are in that marginal area there. Biopsy performed with a more extensive nasal sinus procedure is not reported separately. The most comprehensive endoscopic code should be reported. Flexible and direct laryngoscopies aren't reportable for the same encounter. Cardiovascular, for bypass procedures using venous graft, they include the obtaining of the graft. Cardiopulmonary bypass requires insertion of cannulas into the venous and arterial circulation, so those are not reported separately. Open or percutaneous vascular procedures include the repair and closure, unless, again, that CPT descriptor states the repair is reported separately. So know your CPT descriptors. Venous access code should not be reported when the access is normally obtained while performing another procedure. Again, tons of examples in this chapter as well. Hemolymphatics, abdominal lymphadenectomy should not be reported for the excision of lymph nodes in the operative field of another procedure. Iatrogenic laceration of the spleen that occurs during another procedure. The repair of that laceration with or without splenectomy is not reported separately. Mediastinum codes 39000 and 39010 should not be reported with another procedure on the mediastinal structure for exploration. Digestive system CPT codes 40000 through 49999. Services that are integral to an endoscopic procedure are not reported separately. The same endoscopic performed more than one time in a single encounter in the same region cannot be reported with multiple units. Endoscopy or enteroscopy performed as a standard of practice while you're performing another service should not be reported. Only the more extensive endoscopic procedure should be reported for a patient encounter. If more than one are done, you'll go with the more extensive. An incidental appendectomy during the course of another procedure is not reportable. Again, your medical necessity has to say, why did you take that appendix out? If it's just an incidental, it's included in whatever other procedure is being reported. Insertion of mesh, this is an add-on code indicated by the plus sign by the code 49568, is only reported for incisional or ventral hernia repairs. Laparoscopic lysis of adhesions is not separately reportable with other surgical services. That's considered, you have to do that. You have to get rid of those lysis of adhesions in order to get where you're going, in order to perform whatever procedure you're there to perform. Therefore, it's only not reported separately. Unless that's the only thing done in that operation, those are not considered reportable separately. The urinary, male genital, female genital, maternity care and delivery systems, CPT codes 50000 through 59999, and we'll go through each one individually. Again, I can't overemphasize enough going back to these chapters because there's so much more information that I couldn't put in here. Insertion of a bladder catheter is included in the global surgical package. Placement of a urethral bladder catheter for post-op drainage may not be reported if it's integral to the procedure performed. Some genitourinary procedures include a hernia repair, so make sure you know those. Any minor related functions performed at the same endoscopic encounter are included and not reportable separately. Male genital system, 2 codes from the code range for various methods of removing or destroying prostate tissue cannot be reported together. If a prostatectomy necessitates reconstruction of the bladder neck, the reconstruction is not reportable separately. Female genital system, a pelvic exam performed in conjunction with a GYN procedure should not be reported separately. A pelvic exam under anesthesia, EUA, is included in all major GYN procedures and is not separately reportable. Maternity care and delivery, of course, there's a total obstetrical package, and that could be a whole hour-long presentation, and has been. I've done it before, to talk about all that, but these are just some things that are included. Some services are reportable separately. Antepartum care does include a urinalysis at every visit, so that urinalysis is not reportable. Endocrine, nervous, eye, ocular, adnexa, and auditory systems. There's some examples here. Each individual of these chapters have examples to go back. You can go back in the NCCI manual and look at. So the burr holes cannot be reported unless they're performed at a separate site unrelated to the cranial procedure. Exploration of the fields always included in craniotomies and craniectomies. Ophthalmology, iridectomy done in order to complete a cataract extractions included in the cataract procedure. Repair of retinal detachment codes are mutually exclusive. Correction of triasis is per eye, not per eyelid. Remember that. Iridectomy procedures include tympanoplasty and tympanostomy procedures. A labyrinthotomy includes vestibular function testing and monitoring. So just know these chapters all have things that are included in certain procedures that are done. Radiology services are next. CPT code 70000 through 79999. Scout radiographs before the administration of contrast are not separately reportable. So just about anything labeled scout is not going to be reported, because you're just looking to see what you can see. So you would just report the procedure that's performed. Chest x-ray done to check the location after a central venous catheter insertion is not reported separately. Again, you're just checking to see that location to make sure that the procedure that you did was successful. Fluoroscopy is integral to many procedures and therefore not reported. Medically reasonable and necessary diagnostic CT may be reported separately with an acceptable modifier. Some brachytherapy procedures include calculation descriptions by CPT. 77300. 77300 is a radiation dosimetry calculation. So a lot of the brachytherapy procedures already include that calculation, so you would not report that code separately. Radiologic guidance codes are reported as one unit of service per patient encounter. Next is path and lab services, CPT codes 80000 through 89999. Lots of CPT codes have descriptions that label a test done as a panel. So if all tests in the panel are performed, that panel should be reported. There are edits in place for panel lab tests and the individual tests that are included in the panel. So those should not be broken down and all billed separately. The diagnostic bone marrow aspiration is performed without a biopsy. The procedure is reported with 38220. Interpretation of the aspirate smear is reported with 85097. So if the same provider does both services, they are considered separate services, and they can report that. Blood products described by HCPCS Level 2 P codes. CPT code 86945 can't be reported separately, since the P code includes the irradiation of the blood product. Surgical pathology consultants, CPT 88321 through 88325, they're not reported for a second opinion. They're also examined by another pathologist in the same group, so keep that in mind. We'll go through a couple of slides in regards to the medicine section, evaluation and management services. We'll go with that one first. CPT codes 90000 through 99999. All of these sections are in this manual. I encourage you again to go back and look at those individually, because there's a ton of information in all of those. For E&M services, keep in mind, remember Medicare no longer recognizes consultation codes. So they have information out there, and that's very old. Everybody should be fully aware of that. E&M services are usually cognitive services that do not include significant procedures. So procedures that arise from an E&M are included: dressings, counseling, educational services. Hospital discharge services, they are not reported with an initial hospital care code. or the initial observation care codes. And so there are a whole separate section of codes for when a patient's admitted and discharged on the same date of service, whether that's inpatient or observation. And discharge services includes all services provided to the patient for the date of service. No other E&M service should be reported on the same date of service as a discharge code. So just remember those few points. Supplementary services, HCPCS Level 2 codes A0000 through V9999. The previous principles discussed at the beginning of this presentation do also apply to HCPCS Level 2 codes, and they are alphanumeric codes. They are a supplement to the CPT manual. They include services that are not included in the CPT manual. There's a discussion and many issues addressed in Chapter 12 of the NCCI manual for these HCPCS Level 2, and be careful when you're reporting those J codes, because make sure your units of service is correct based on the amount of the drug given. Each drug code has a unit of measure that's applied to it. Double check the MUE section of this chapter for lots of information there. Category 3 codes, CPT codes 0001T through 0999T. Again, previous principles apply in this section as well. Category 3 codes are for emerging technologies, services, and procedures. They are referenced with codes from the CPT manual. The most specific HCPCS CPT code should be reported for the service provided, even if that code is a Category 3 code. So if you're performing Category 3 code procedure or service, you need to report that code rather than an unlisted, quote-unquote, regular CPT code. So if a Category 3 code most specifically describes the procedure or services you're performing, that's the code that should be reported. And that's the end of the presentation. I'm a little bit over an hour. Sorry about that. But these are the references tools for your review. And I hope you learned a lot today. I do hope that you go back and look at the NCCI manual, because it has invaluable information in it that will help you in your coding and make sure that you are capturing your services appropriately and in the best format possible. Thanks again for listening to the presentation. I hope you have a great day.